Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. I'm excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Kevin Day. He's co-chair of the Privacy and Consent Workgroup at the Sequoia Project. And Mel Soliz, she's co-chair of the Privacy and Consent Workgroup at the Sequoia Project. Welcome.
Thank you. We're happy to be here.
Yeah, I guess I could have said you're both just co-chairs, but anyways, I'm excited to have you here to learn more about the hard work you're doing, with the Sequoia Project and their work groups. Mel, why don't you start us off? Tell us a little bit about yourself and the privacy, details about the privacy and consent work group.
Well, I'm a health data privacy and interoperability attorney with Coppersmith Brockelman. Coppersmith is a boutique law firm that's nationally recognized for its interoperability practice and complex commercial litigation. And in my practice, I help tech-enabled healthcare organizations design, operate, and defend data sharing platforms from launch through compliance and disputes. And I have the distinct pleasure of representing Contexture, who is a Sequoia Project member and the statewide health data utility in Arizona and Colorado on the Privacy and Consent Work Group. Now, the Privacy and Consent Work Group was established by the Interoperability Matters Leadership Council of the Sequoia Project. And this particular work group brings across the healthcare and health IT communities stakeholders to really identify, prioritize, and collaborate on privacy and consent issues. And over the last 2 years, our work group has really been focused on two primary topics. One, computable consent, which refers to receiving requests for information to determine the level of exchange permitted based off the laws that apply to that data and what the individual wants done with their data, and to be able to share it electronically in a computable format across different platforms. And the second is data segmentation for privacy. Obviously, in order to operationalize computable consent decisions over what should and should not be shared, we also need to be able to identify and segment the different categories of health information that is being authorized for sharing. So, our work group has published some really exciting white papers and guidance documents and other materials that are coming out later this year. And I'll hand it over to Kevin to talk a little bit more about himself and his role as co chair.
Perfect.
Hey, thanks, Mel. Again, thanks, John. Appreciate your time today. Kevin Day, I'm a principal business advisor at Edifex, which is a Cotiviti business. My role is a principal business advisor. So it's a cross-section of domain expertise within the healthcare space as well as the technology behind it. And I advise our product team around standards, regulations, in our interoperability in general, but my specific focus is around the digital aspects of consent management in this growing world that we're in. So along with Mel, co-lead with the Sequoia. Addition to that, I also am a co-lead of a work group within the HL7 FAST Fire Accelerator, the consent management work group that I'm also a co-lead on. And so the intersection of the two is very exciting for me. I'm able to cross-pollinate information across the two organizations that I help co-lead.
Yeah. Well, I think Kevin, you said it right. This is one of the biggest topics happening. How do we manage privacy and consent and ensure that people trust and believe that their data is being protected so that they want it shared. So I appreciate you both coming on to talk more about the work you're doing, and it's great to hear you're coordinating it too, because I think we can all appreciate how important that is, in this space as well. Mel, why don't you kick us off talking about like what are some of the big trends you're seeing in privacy policy at both the federal and the state levels?
Well, at both levels, privacy laws across the board are getting more granular, more fragmented, and as a consequence, they're simply more difficult to operationalize across technology platforms and across state lines. So at the federal level, we're seeing really strong pushes, especially by this administration, towards national interoperability and access. While the privacy rules still largely assume kind of static organization bound data within a single state's jurisdiction. And the problem with that is that while the federal government may be pushing towards national interoperability, they're requiring that it be done without preempting any of the existing federal and state privacy laws. So we're compounding this issue by requiring both share the data, but don't share the data if there's something else that would require you not to. And at the state level, what we're seeing is not really a push necessarily towards interoperability, but more of a rapid expansion of sensitive data protections, especially around categories of sensitive healthcare services like reproductive health, behavioral health, genetic data, and cross state data use. At the same time, we are seeing in real time organizations in this space using data privacy and interoperability laws to advance competing objectives, thereby increasing the risk that healthcare organizations face if they decide to participate in data sharing platforms or activities. And the challenge with these federal and state laws is that they're all written in legal or policy terms. They're not written in clinical terms or technical ones. They express important values for states, but they don't always translate cleanly into how our technology and our health IT systems actually operate. So put that all together. We now have this big disconnect that's creating some of these big risks to both privacy and data sharing. And that's what our work group is essentially trying to solve.
Interesting. I mean, when you describe that state situation and kind of the different laws across each one, like as you look across those states, how much divergence is there in the privacy policy? I've seen that as well in the state that I'm in, right? It's all about the privacy. It's not about how can we facilitate sharing. It's like I want to protect our citizens. It feels like to me in many states that's the case. But is there a lot of divergence between the privacy policies that are being implemented in each in each state? And what does that mean for an organization? I think most healthcare organizations are crossing state lines these days. So what does it mean for them?
Every single state has its own data privacy laws. Some are way more restrictive, some are less, but it's true for all 50 states. And the divergence is significant and it's accelerating. So states are essentially making different policy choices about what is sensitive, what is not, when is consent required, when is it not, and when data can even cross their state lines. Now, for organizations who are often operating nationally, right, like a health system might be in Arizona and California, and they might have a single electronic health record system. What that means for organizations in this space who are not operating within strict state boundaries is that they're trying to comply with literally dozens, if not hundreds, of overlapping and often conflicting rules inside technology systems that were simply not designed to interpret all this legal nuance, even when you throw AI into the mix. Like, I love what AI might prove to help with all of this, but even with that, it doesn't solve for all these conflicting and different rules. So what's happening is that in practice, what we're seeing overblocking,
Mm,
undersharing, inconsistent application of privacy protections, not because organizations want to do that, but because there's certain realities to their technology systems and trying to comply with all of these really complex state laws. And none of this ultimately serves patients, providers, payers, or even regulators well. So without a common technical foundation to say these are what these different sensitive data categories are, even when we have really good faith compliance by all these organizations who want to protect privacy and then also, advance interoperability, it just becomes incredibly hard to sustain.
interesting. Kevin, I want to get you there, but I want to dive into that a minute, Mel. So what you're describing is they're often not sharing information because they have to comply with one state and their IT doesn't support, expansive in one state and restrictive in another. Is that kind of what you just described?
Yeah, it's very common for healthcare organizations to be operating, let's say, in three states. Maybe they're California, Arizona, and Utah, for instance.
Sure.
Their technical systems are all the same, though. So California has one set of laws, Utah another, Arizona another, in order to comply with the most restrictive preconditions among all those states. And you have to keep in mind, California, for instance, might more heavily regulate genetic testing information, and Arizona might more heavily regulate substance use disorder information. They have to take the most restrictive conditions across all three states apply it to their technology system. And what you have happen is you have the patient in Utah who says, I want to do this with my data or share my data with this person, or you have the hospital wanting to send the data over to somebody in Utah. But because their technical system has to be written to the most restrictive state law in like California or Arizona, they can't send that data for the Utah resident. And the patient in Utah or the provider in Utah is kind of left scratching their heads as to why is this happening? That's an example of kind of overblocking, not because they're doing it intentionally because they don't want to share the information, but because the way their technical systems work, the only way they can comply with the most restrictive law is to essentially do it for all of the data in that data system, if that makes sense.
Yeah, no, that makes a lot of sense, and is really complex. Kevin, Mel just painted this rosy, beautiful picture. No, I mean it's the reality of the complicated
It
network
is.
of laws and privacy laws and infrastructure that's there. So, can technology help? And what kind of technology or technical tools could ease this burden and allow the data to flow, with the necessary safeguards and address kind of the challenges we just described?
Great question. And the good news, let's start with that, is the technology absolutely does exist. But in order to, it exists today, but in order to create, maintain, and really enforce healthcare consumer PHI disclosures that Mel talked about in the various complex situations, what the industry really lacks right now is a clear path forward in the manner in which these technologies that do exist should be implemented and implemented in a way that's consistent across different organizations. Because if one organization, like one hospital system, defines and encapsulates in a computable, granular consent manner, of which our guidance are leading them the path to explain how they can do that. But it needs to be consistently applied because it's that PHI, and that's the world we're moving toward. As PHI is shared across different entities, there needs to be a consistent means of which that PHI is disclosed, right? And really and so the technology is there. What it lacks is a guidance to how to consistently apply the technology in the industry.
Yeah. I imagine that's one of the big efforts of the privacy and consent work group that you co-chair to address that. Kevin, tell us more about who's involved in that work group and some of the various perspectives that are part of the work group and who's coming to the table to help solve this challenging problem we just described.
Again, great question. One of the most exciting things I think about our work group is we have a great representation industry from legal experts such as Mel and other lawyers that specialize in this, into technicians beyond myself, but other ones that actually implement solutions within the health system space or the health plan space, HIE, so forth and so on. But even more so, and that I get really excited about, is the involvement of the operations staff within organizations, the ones that live and breathe this issue, that deal with having to collect consents, actually work on the disclosure of PHI in various scenarios. So their involvement has been very critical, especially in the last year on one of our forthcoming guidance documents.
Interesting. Mel, what would you add as far as who's involved and kind of the different perspectives and what they're bringing to the table to solve this problem?
Well, I would just add that we really are genuinely multi-stakeholder. As Kevin was saying, it's providers, it's networks exchanges, it's EHRs, it's other health IT vendors, but it's also application developers, individual privacy advocates, and individual access advocates. Policymakers are also part of our group. And each of these groups sees a different part of the problem. And that's why it's important that this group is multi-stakeholder, because you need all of those different perspectives in order to come up with solutions that actually work. The other thing that I would add is we are all very intentional about grounding the work we're doing in real operational use cases and not just theory. And that's what I'm so excited about this guidance document that we will release the final published version later this quarter, because it does exactly that. It is providing concrete guidance to states on how do we make computable consent a reality. And it's the first step towards that.
Yeah, that's one of the things I love about the Sequoia Project when I've been to the annual meeting or even seen the work groups and things that they're doing. They do try to incorporate all of the perspectives, including patients, which often sadly don't get represented. Sequoia Project does a good job of making sure that everyone's involved and their voice is heard. So it's great to hear that you're seeing that in your work group as well. Mel, you mentioned the guidance. Like, what guidance has the work group published for states? What's coming? What should we expect as far as guidance coming out of the work group?
Well, last year you might have seen our white paper called Moving Towards Computable Consent, a Landscape Review. That was published under the leadership of the then co-chairs, Devin McGraw and Dr. Stephen Lane. It is a wonderful review of the current landscape of privacy and consent management in healthcare. It identifies the problems and the challenges, from legal and policy challenges to the operational and implementation challenges, and then also identified some of the pilots and the solutions that are being developed and tested. And it was really foundational to the work that Kevin and I have been doing over the last year and into 2026 with our guidance to states document. This is a guidance document about legislating technical standard definitions for existing state sensitive health data laws. And what it is, it's designed to help states make their existing sensitive health data privacy laws enforceable in modern interoperable systems. So, what I mean by that is it provides a very practical framework for states to align their existing legal definitions of sensitive health data with nationally recognized technical standards so that these different technical systems and platforms can consistently identify and protect that data as it moves across platforms and as it moves across state lines. And this is really critically important about how practical the Sequoia project is and how our work group is very practical in the guidance that we are given. We are doing this in a way that preserves state autonomy. States don't give up policy control over what data is sensitive. They already have those laws on the books. What they gain is a shared technical language that allows those policy decisions, and each state's going to make different policy decisions, but to allow them to be implemented reliably in technical systems without essentially breaking interoperability or forcing organizations into defensive data blocking. So, in short, I think what it does is it gives state policymakers a blueprint for building that bridge between those state privacy laws and the technical standards that Kevin was talking about that the health IT systems need in order to enforce those privacy standards at scale.
Wow. I had a representative in my state reach out to me about this. I just need to forward them your work. I love that. That's that's great. We
Exactly.
definitely need it in Nevada. Kevin, what does it mean, kind of from the perspective of those managing the data on the front lines? What does it mean for them, and how can they use the guidance?
Great question. So, what's one of the other work streams or deliverables we're going to be releasing shortly is an operational guidance document. That the issue there is that instead of boiling the ocean, as you can imagine, it's a fairly complex situation and it's very situational based. So what we did was we came up with a very relevant but very specific use case around doing part two data and the sharing of that in a very common scenario that the industry is facing right now. And then we've broken that down into saying, okay, let's work on, well, what does that situation require in terms of information you need to encapsulate for a disclosure to support that use case? And what's the operational aspect from the beginning of the request, the individuals, the organizations involved? All right, what's the data involved? And then as it goes through disclosure from one organization to another, what's the operational process look like? So we're building at the building blocks, of which a key aspect of that is what Mel talked about when it comes to the terms we call provisions, the language that the law states, but now we're working towards saying, how do we encapsulate in a form to support a very specific use case? What does that disclosure form look like? Then we break the disclosure form down into kind of computable or nameable pieces that then we move toward encapsulating that in a computable, granular manner so that it can then be shared through that operational process end to end.
Wow. I love it that it's not just a document that sits there and no one uses. In both
Right.
cases,
Yeah.
relevant to regulatory actions and legislative efforts, but also to operational ones. I love that you're approaching it both ways. Kevin, maybe could you tell us how can people get involved? I imagine you want feedback on this, and it's an iterative process, or how can people get involved or share their feedback? As you put it out the guidance, or even create the guidance. How can people be participate?
We absolutely encourage involvement. Involvement comes in two fashions. Of course, first and foremost, we would love to have members join Sequoia and join our work group because that's where they can really have the most impact on our work. So we're very much open and highly encourage interested individuals to go ahead and join our work group as an actual member. Outside of that, we do publish these for public consumption and input. As Mel mentioned, the state guidance document has already been out there. We've collected public input. Our operational guidance is coming up and it is being released for public comment in the next few weeks. So again, we highly encourage the public when that does get released to please provide any feedback that they can provide us.
Awesome. Well, we'll be sure to include a link to the work group so people can go check it out in the article as well. And appreciate you both hopping on to share about all the work you're doing. It's a complex process that you're working on, privacy and consent. So, but it's so important to patients and the providers who care for them. So, appreciate all the hard work that you and your committees and work groups are doing. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks so much.